So one of the things that people have been confused with for years and still are is arrhythmogenic cardiomyopathy. And that's one topic that we were asked to do. And so we have a double-headed monster of a presentation with Kathryn from Leeds and Desley from Birmingham telling us all about arrhythmogenic cardiomyopathy. So please come forth. Thank you.
Thank you. So I'm going to start, and I'm one of those brand new baby consultants. I've only been in post a couple of months, so I'm in no way pretending to be an expert on this at all, but hopefully I'm going to cover some of the basics, and then Des is going to cover some cases and talk a bit more about the genetics. And I have to say that when I first started looking at this, I was just like, well, it's fat and fibrosis, like, why are we getting worked up about this? It's really straightforward, isn't it? But actually, it turns out, if I can move this on, can I move this on? Yes, that it's a bit of a nightmare, and that's because the definitions are continually changing, really, and it's predominantly been led by clinicians, as it probably should be. But the plan today is to try and find a little bit of a way through the maze, give you an approach from the pathology or the pathologist's perspective, walk through history and kind of show you why things have changed, and then take you through some cases and the evolving genetics. So we can maybe come away all together at the end, probably following a discussion with everybody, where we can talk about what is ACM. So the original description of myocyte depletion and fibrofatty replacement was first reported in the literature in 1982, or actually probably in 1978 in French, but we all know that the medical literature is only in English. So it was first described in 1982. And that was of a case series of 24 patients in Paris who had replacement of their right ventricle by fat and fibrous tissue. And there was then a clinico-pathological study on a population of young people, all less than 35, 12 patients in the kind of northeastern region of Italy, and they had all died. They were all athletes, as like I say, young people, and again showed this myocyte depletion and fibrofatty replacement. And the initial thoughts were really that that replacement was probably a congenital defect, so a problem with myocyte and myocardial development, and hence it was initially designated as a dysplasia. And then as genetic and phenotypic understanding has evolved, the name has been changed to an arrhythmogenic right ventricular cardiomyopathy, or a heart muscle disorder. And you will sometimes see ARVC stroke D or ARVD stroke C used as a way of trying to maintain those historical ties, but I wouldn't recommend adding in anything else that's going to confuse this. The original disease phenotype was characterized by predominantly right ventricle involvement, but clinical variants with either parallel or even greater left ventricular involvement are now increasingly recognized. And so we would normally use that term arrhythmogenic cardiomyopathy, with some people advocating the use of the term ACM phenotype to encompass those entities which are as yet incompletely understood, and we'll come back to some of that terminology in a second. But I think what we need to try and do is, as a group, make sure that we're all describing the same entity when we're using these terms in our reports. So this is just a slide that shows some of those original reports of ARVC as was then. But this kind of gives rise to this common definition, actually. If you go to the literature, this is what's commonly referred to when we use the term ACM, this genetically determined heart muscle disease characterized pathologically by fibrofatty myocardial replacement and clinically by ventricular arrhythmias and sudden death. Some people still advocate that we should very clearly be saying whether we're talking about a classic ARVC phenotype, so that dominant right variant pattern. Are we talking about a biventricular variant or a dominant left variant, also known as ALVC, again, when you look back at the literature. And this usually clinically, that, you know, determining what pattern we have is usually determined by imaging and much less frequently by histology. But in 2019, the Heart Rhythm Society put forward a much broader definition. And so they described an arrhythmogenic heart muscle disorder not explained by ischemic, hypertensive, or valvular heart disease. And I think this possibly is where some of the confusion and the difficulties have arisen, because this, when you read this paper, would include systemic conditions, so things like sarcoid and amyloid. It would include inflammatory conditions like myocarditis, and as well as those genetic disorders that we know cause ACM and that we'll talk to. And that, I guess, kind of makes ACM somewhat analogous to something like cirrhosis, where it's a pathological process but not a diagnosis. And I think a lot of people have really struggled with this. And yet there are others who restrict ACM to desmosome related pathology only, and we will come to the kind of the structural issues and the genetic mutations. But you can see there's already confusion, and we've only just started talking about the definitions. So before we get too bogged down in the definitions, how do these patients present? Well, the clinical presentation ranges from completely asymptomatic to sudden cardiac death. But the most common presentation is one of ventricular arrhythmias, palpitations, and syncopal episodes, most commonly during exercise, and as we know, cardiac arrest and sudden cardiac death. Those ventricular arrhythmias are worsened when you get adrenergic stimulation and neuroautonomic imbalance, as occurs during exercise and also immediately just after exercise, and that's why they tend to occur in association with exercise. But the presentation can stimulate acute myocarditis, so it can be confused with that, with chest pain, ST elevation, T-wave changes, and it can also be missed, and so that patients end up actually presenting with a late stage presentation of a kind of a biventricular heart failure pattern, and they may be misdiagnosed as idiopathic DCM. Classically, the right-sided disease is kind of thought of as having 4 phases. So a concealed phase, where you don't have any detectable or only very subtle right ventricular changes, but you can still get ventricular arrhythmias and sudden cardiac death. And then a stage where you have your arrhythmias in association with some of those functional and structural abnormalities. And then you end up getting progression of your right ventricular muscle disease, which eventually progresses to a biventricular pattern. That's the kind of how it was classically described. But it's worth seeing in all of this that the pathologist is often not involved at all. And the cases where we are involved are those that come to PM, those that will be seen in transplant centres, very rarely in LVAD cause, although as I'll talk about, that's not a good site to be looking for your right ventricular disease, and very, very, very rarely for endomyocardial biopsies as well. So again, if you turn to the literature, the epidemiology is often cited as between 1 in 1,000, which is probably too high, and 1 in 5,000, but the reports go anything up to 1 in 50,000. So it's clear that we're not entirely sure what we're talking about. Initially, it was thought to be more common in Europe and in places like northern Italy because of those initial case reports, but it's now known that it's can occur throughout the world. It can be part of certain syndromes, and these are the syndromes that have helped lead us to some of the genetic causes of ACM. So I'll come back and talk about these, but these are things like Carvajal syndrome and Naxos disease, and these are ACM that is seen in association with very typical cutaneous phenomenon. So hyperkeratosis on their hands and feet, for example, and this kind of characteristic woolly hair. So ACM is a leading cause of death, and in most of the reports that you read, there is a quoted higher incidence and severity in men. Now, whether that is actually effect on because of sex hormones, or whether it's to do with exercise and exercise intensity, it's not really very clear yet. In terms of how ACM is diagnosed, there is no single gold standard diagnostic test. I was out with some cardiologists last night who were telling me that they have to do a whole panel of different things in order to be able to make sure that they've made a diagnosis. And as with most things in medicine, if there are lots of different ways of doing something, it probably means that no one of them is particularly good. So I think diagnosis clinically best achieved by combining multiple sources of information. So in terms of the arrhythmias, the cardiologist will look for things like negative T waves representing repolarization abnormalities. They'll look for prolonged QRS complexes, things like that. They will perform ventricular stimulation to look to see whether they can induce ventricular tachycardias, and And so there are some quite characteristic changes that make up some of the diagnostic criteria. We'll talk about the genetics and the histopathology in a second. But in terms of imaging, previously this was based on angio and echo, but right ventricular angiography showing areas where the right ventricle isn't moving properly, so systolic akinesis or dyskinesia, and then later on some bulging within the right ventricle and aneurysm formation. But echo, obviously non-invasive and good for serial examinations, but the gold standard in terms of diagnosis really now is considered to be gadolinium enhanced cardiac MR. And that has a much greater sensitivity for some early changes, but there is it is prone to a lot of inter-observer variability, and it can lead to overdiagnosis. So these images show, I'm not sure if let me see my pointer. Yeah, so we've got some right ventricular dilatation, but we've also got these kind of sacculations here. This kind of, it's not a nice smooth wall, and then you get this kind of classic bite-like pattern of the hyper enhancement here around the wall. So apparently these are key if a cardiologist was looking at this. So the original diagnostic criteria for diagnosis of ARVC, as it was back then, were based on the structural, the histological, the ECG, and the familial features of the disease. And they divided these criteria into major and minor criteria, a bit like for endocarditis or something like that. And whether they were deemed as major or minor were all based on the specificity of the association with ARVC. They all focused on the right ventricular manifestations because that's what we knew about at the time. And they were kind of dominated by those case series and therefore by the severe end of the spectrum. So they were highly specific, but they lacked sensitivity for early forms of the disease and for familial disease. These were then revised about 15 years later to include more ECG markers, to include more quantification of imaging, and also to allow for the inclusion of known pathogenic mutations, which were just starting to come into being at that time. But these were reviewed by an international expert kind of panel and were found to be limited, and this panel suggested areas for improvement. And so the Padua group, who many of you will know are prolific in their kind of reporting of cardiac pathology and their work in the literature, they put together a multidisciplinary set of criteria which were revised from the earlier ones and based on their 30 years plus of experience. And they really highlight the importance of viewing ACM as a structural heart disease. So just because you have a mutation or a clinical phenotype, you need to have actual evidence, whether that's histopathological or imaging, of that kind of structural problem. So our pathology bit probably hasn't changed that much actually as we go through the diagnostic criteria, although obviously there's been that shift from seeing this disease as a purely right ventricular phenomenon to one that can affect both ventricles. So what we're most interested in as pathologists and as an autopsy pathologist for most of us is what we're going to see down the microscope. So the original reports of ARVC or ARV or ACM referred to infiltration by fat, myocyte degeneration, and variable inflammation, and made reference to this idea of a triangle of dysplasia, with the most affected sites being the anterior infundibulum, the right ventricular apex, and the diaphragmatic aspect of the right ventricle, as is shown on the diagram. And kind of as things have evolved and as more and more reports have come out in the literature, there's obviously some key examples, and actually these images appear in not just this paper, they appear in lots of different papers, so they're kind of taken almost as classic examples of the histopathology, showing the right ventricular wall thinning, aneurysmal dilatation, that fibrofatty tissue replacement, and then these kind of islands of residual myocytes, often just combined to the trabeculae. And then in D, so the other side of this image panel, you've got your biventricular disease, again with, in this case, more severe right ventricular involvement, but also left-sided involvement with replacement type fibrosis. The boxes show some of the macroscopic and microscopic features as outlined by Prof. Shepherd in her group's paper of 2019. And that was a paper that looked at their sudden cardiac death cohort and reported that they saw some, if not predominant, left ventricular involvement in the vast majority of their cases. And you might recognise the numbers at the bottom from Prof. Shepherd's textbook, if that's one that you use. And they state that fat and fibrosis is required in at least 20% of at least 2 tissue blocks. These are just some more examples, again, showing that right ventricular dilatation, the fatty replacement, islands of kind of leftover myocytes and variable inflammation. But I just wanted to kind of bring out that just the fatty infiltration on its own, which is commonly seen in the right ventricle in the normal heart and which increases with age and with increasing BMI, is not sufficient. It's that combination of the fatty infiltration and the fibrosis as well as the myocyte degeneration that you're looking for. So in terms of the patients we see in the mortuary, they're quite often, I think, this patient group in the middle. And sometimes the changes that you see are going to be very focal, but I think it's worth remembering that there is this whole phenotypic spectrum, and that spectrum is probably a lot wider than was previously understood. And a few more things that I've kind of picked up as I've gone through to try and prepare for this is that it's thought that atrophy occurs over time, probably starting from the epicardium and extending towards the endocardium. So this idea of this outside-in progression, and that eventually becomes transmural, and that it's probably not a continuous progression, but it occurs in kind of little periodic bursts of things getting worse. And it might be in those periods of things getting worse that, again, that you get that kind of clinical presentation, which might mimic other things like myocarditis. Just for reference, and because I thought it was interesting, there is some evidence that you get increased viral, if you look for it, there are increased viral genotypes found within hearts from ACM patients, but the thought is that this kind of this milieu of dead myocytes is just a good place for viruses to hang around rather than necessarily that they're causative. So if we go back to the beginning, and that kind of definition that has been purported of this kind of genetically determined heart muscle disease, we're now starting to talk about a disease that is increasingly recognised to be potentially genetically heterozygous, depending on how you define it. But it's not that long ago that very little was known about the genetics. And these insights came from those syndromic cases that I mentioned before. So Naxos syndrome, for example, I mentioned this cohort of people with the palmoplantar keratoderma, which was the term that I couldn't remember a minute ago, and their distinctive woolly hair. And by looking at those patients and by performing homozygosity mapping and linkage analysis, it was identified that the problem was with a gene on chromosome 17, and that was a problem with the JUP or JUP gene encoding plakoglobin. And then similarly with Carvajal syndrome, which is a very similar syndrome, the mutation was localized to an area on chromosome 6 in the desmoplakin gene. So we're talking about 2 genes which are both involved in the desmosome. And so I thought it was worth having a quick recap, because I don't know what everybody's remembrance about the desmosome is, but these proteins, so plakoglobin and desmoplakin, are both components of the desmosome, and they're both and the desmosome is cell structures that are important for cell-to-cell adhesions. So they're found not just in cardiac myocardium, they're also seen in other areas that are exposed to high mechanical stress, so things like within the bladder and within the gut. And I think when I think about them, I kind of think of them as a bridge. So this kind of structure which links intermediate filaments in one cell with both the cell membrane, and then bridge over into the next cell and links with the next intermediate filament. So they confer kind of structural stability, but they're also involved in crosstalk between cells and contribute to electrical activity. And so this is just a close-up of that disc area, and it shows the desmosome and its composite proteins, and it also shows the adherens junctions. So that's the kind of the pinky one down at the bottom, which link actin filaments rather than intermediate filaments together. So it kind of makes sense that in science, if you found something that's mutated in 2 different proteins, both within the same area, then maybe we should look at all the other proteins that are involved in the desmosome and see whether they're also involved. And so research first looked at, like I say, the desmoplakin and then the plakoglobin genes, and then went on to focus on other components of the cardiac desmosome. And it's definitely true that desmosome mutations represent the most common cause of arrhythmogenic cardiomyopathy. And some people would say the only true cause, and that's what Desley's going to come back and talk about. But mutations causing a similar ACM phenotype have also been identified in components of the nuclear envelope, in the intermediate filament, in the adherens junction, as well as in the sarcoplasmic reticulum, and in other proteins which you might commonly see have associated with other pathologies. So mutations in the SCN5A, so a sodium voltage gated channel, which is a cause of Brugada syndrome, has also been shown in 2% of patients with arrhythmogenic cardiomyopathy, and mutations in TGF-beta3, which some of you might recognise as being involved in aneurysm formation, so Lewis-Dietz syndrome, have also been implicated in arrhythmogenic cardiomyopathy. I'm not going to go too much into the pathogenesis because it is complicated, but the simplest kind of explanation is that these desmosomal mutations lead to loss of adhesion between cardiomyocytes, and that predisposes them to detachment and death, and that they are then replaced by fibrofatty tissue. Exercise exacerbates this adhesion defect, and the idea is that this is of greater consequence for the thin-walled right ventricle than it is for the left, which is why exercise is known to exacerbate this phenotype. So if you're involved in endurance sports, for example, you are much more likely to become symptomatic at an earlier age. You have an increased likelihood of an overt phenotype, and you're much more likely to get ventricular arrhythmias, heart failure, and die. There are other pathogenic mechanisms by which this disease may result. So desmosomes, as I said, they're not just there for structure, they also help to with the intracellular signaling pathways, and alteration of the desmosome leads to suppression of the canonical Wnt signaling pathway and increased adipogenesis. And Martin mentioned about mouse models. This is recapitulated in various different mouse models where these mice with mutations in things like the DSP gene get fibrosis and fatty infiltration. These mutations can also lead to problems with the hippo signaling pathway, and that pathway gets its name because loss of function leads to overgrowth in a hippopotamus-like fashion. These scientists and their crazy names. And so that pathway plays important roles in cell proliferation and apoptosis and things like that. And there's also, there's loads of literature out there talking about adipogenesis and how that can be affected. And like I say, about how these desmosomal proteins interact with the cell signaling within the heart and lead to this arrhythmogenic phenotype. So it's not just that you get fibrosis and fat, and that leads to scarring, and that's like a focus of your arrhythmia. There's actually other things going on as well that lead to the arrhythmias before you have those structural phenotypes. So hopefully not too much blinding by science. Shall I come out, Desley, and then go into your one? We're going to go through some cases and some genes. This one, I think it is. And then have a discussion, I think, probably, haven't we?
If we've got time. So, afternoon, everyone. I'm Desley from Birmingham, for those of you who don't know me. And so I'm just going to run through some cases of mimics of ACM, or are they mimics? It's all a terminology thing, I think. Yeah, we can then come up with some thoughts at the end. So the first case, I just might try and move this to the top where it's less likely to block things. So it's a 42-year-old man with a strong family history of dilated cardiomyopathy and complete heart block. He was fit and well till 3 years previously when he presented in complete heart block, had a pacemaker inserted. He continued to deteriorate. It was replaced with a CRT, so a defibrillator device. same time, his brother was being assessed at a different transplant center. And anyway, he ended up having a cardiac transplant. So I guess the other thing I should say is I'm not really a PM pathologist. I do the explanted hearts.
Okay, here we've got a section through the ventricles. The heart was 290 grams, so not a particularly large heart. Hearts are always a little bit less in the explanted hearts because both atria remain in the recipient. You can see in the right ventricle that there's a lot of fat around the outside, but there's sort of an irregular outline with the myocardium, and it looks very thinned in places. Also appears to be some sort of fatty change within the left ventricle. Here's the histology of the right ventricle, and it, very obvious fibrofatty replacement of the right ventricle, full thickness in places. And in the left ventricle, there's also epicardial fibrosis and fibrofatty change in this area, with a little bit also in the subendocardial distribution.
So apart from that, there was also a bit of disarray around, not completely swirly, but fibers sort of heading in all sorts of directions. So this case ended up being discussed at the Inherited Cardiac Conditions Clinic. I think everyone would accept that it's definitely got an arrhythmogenic cardiomyopathy phenotype and possibly a hypertrophic one. And so this is a long time ago, back in the predating all the panels, and we were having to come up to try to help the geneticists work out what genes, individual genes they were after. So what genes to test. And so I said, well, there's arrhythmogenic or hypertrophic pathways to go down. The clinicians, I remember them the cardiologists just shaking their head, it didn't make sense for any of these. Anyway, 5 years later, they come back to me and said, oh, Desley, we found a Desmond mutation. Could this be Desmond cardiomyopathy? So just quickly run through what Desmond is. So Desmond's an intermediate filament. It joins all the sarcomeric proteins, the sort of myofibrils, the thin and thick filaments together at the SED band, the SED disc, and also links to the nucleus and the cell membrane. And when it's abnormal, it forms clumps, interferes with all sorts of things, but you get clumps forming within the cytoplasm. So I went back and got the electron microscopy done. My theory at that stage was if I could come up with some sort of clue histologically, which I thought I'd come up with 2 clues, I didn't need to do anything further. Anyway, so EM came back, and here, sure enough, you get this very dark SED disc sort of coloured, which is very dark, granulofilamentous, they describe it as material within the cytoplasm. And here's a higher power. There's your desmosomes or your intercalated disc up here. And so to me, this is a Desmond cardiomyopathy, not an arrhythmogenic cardiomyopathy, which I think is anyway, it's down to terminology. So that this is for discussion and what we think at the end. So the next case, 42-year-old female who had a cardiac arrest in 2004, which was then, she obviously was resuscitated, and she then had progressive heart failure, which was right heart failure, which was then followed by left heart failure, and she ended up requiring a transplant in 2011. I think the other thing I'd say at this point is, from the genetic perspective, it was easier to get genetic testing done if you died. If you were lucky enough to survive, you sort of missed out on the first round. And I might just have to move this somewhere else. So the explanted heart again, once again, not brilliantly easy to see in here, but there's fat coming in on the right ventricle. There's something going on the epicardial, so fat and probably a bit of fibrosis coming in from the epicardial side of the left ventricle. Sorry, once again. And this is just a further section, and I think the fatty infiltration of the right ventricle is really quite pronounced in this one. The other thing this person had was an area, so in the right ventricular outflow tract, a quite discrete area where there's no muscle whatsoever. Just the histology, so right ventricle, fibrofat, or certainly some fat, and a higher power, you can see there's fibrosis amongst this, so it's fibrofatty infiltration, and this is that area in the RVOT where you've also got scarring and fibrosis. So I think everyone would agree that that fits into the arrhythmogenic cardiomyopathy phenotype. So this time, 12 years later, I copied it into an email from the geneticist to the cardiologist and one to me, and basically saying that they've, well, I guess come down to mine. After absolutely years of hunting for a mutation, we found a lamin C variant. So I then went back to the specimen. I'll quickly run through what lamin C is now. So this diagram is, so this is the nuclear membrane, there's double membrane on the nucleus. So this is the outside of the nucleus. And this blue squiggly line here is the lamin C. So it forms a scaffold and is meant to help with the sort of the rigidity and the structure of the nucleus. And just of note, this is where the emerin is. So that's in the nucleus as well, on the inner membrane. So I do a lot of immunohistochemistry on my hearts, and I hadn't done it in this one from back then. And as I got preparing for this talk, I suddenly was looking at it, and I don't know how, I think it's coming out from reasonably there. So this is normal. So it stains the nucleus. So it's a perinuclear stain, and normal, everything's staining. This is a blood vessel here. So the smooth muscle staining here, and this is, so this is an ischemic type heart, so a control, and this is this person's heart, and you can see, I hope, more easily on the screen, that the myocyte nuclei actually aren't staining. So it's, it confirms what they found genetically. So to me, this is not ACM. This is now a lamin C or a LMNA, which is the name of the gene, cardiomyopathy. Third case, 45-year-old man presented with shortness of breath, low ejection fraction, normal coronary angiograms. Anyway, he had a DCM, but they also, possible ARVC, transplanted in June 2012. And I think this is finally, we've got some nice pictures here, and I think there's absolutely no doubt that there's very little muscle within this dilated right ventricle. Here with the light behind it, you can see, the light shining through, and you can see that there's no muscle in the wall, and a little bit of fat in the outer left ventricle. Once again, just quickly through next picture. So this is right ventricle, and there's certainly fat coming in and a bit of fibrosis. Another area, actually I know what I'm coming on to here, and a little bit of fibrosis in the epicardial aspects of the left ventricle. So at this stage, I thought it had an arrhythmogenic cardiomyopathy phenotype. I also, at the time, thought that there was a bit of disarray. When I was looking at it for this, I was less convinced, but I thought that, it would fit into the ARVC phenotype. Towards the end of 2014, I was contacted to say that the person had been referred to genetics. They were going to be seeing the geneticist soon. And so I took it a bit further forward. I requested the EM and the immunohistochemistry to be done. And I found, these are two, this is, the person at lower power here, this clump of dark material, fibrillary clump of dark material. And I put this diagram in to try and help you explain where we are. So it's more of a transverse section than a longitudinal, which is what we would normally like. And it's in the region of these myofibers. So you've got the clumps. This is all the clumps of thick and thin filaments transversely cut. the higher power, you can see them here, and it's sort of within those areas. The SED bands are dark, and so it seems to be related to the SED bands, which are abnormal, but you've got these sort of SED band material around it. So it seems to be related to that. Higher power, you can sort of see it here. And at the stage, I said, I hadn't seen it before. I don't know what this is. It might, I actually sent it off to Annalisa Angelini in Padua, because they did a lot more electron microscopy. Basically, she didn't know what it was either. And so my email to the geneticist was, I don't know what this is. It might be might fit in the myofibrillary spectrum, which is what Desmond is in that, any of the filamentous proteins that aggregate. It could fit into Nemeline rods, which is what the term they use in skeletal muscle pathology. But I thought that maybe should be, a younger person, and at this point, I think this is it, bring on the 100,000 genome project so that we can actually work out what all this stuff means. Anyway, a few months later, she comes back to me with the mutation report, and she said, we found a variant of uncertain significance in two different genes. One's the lamin AC, which we had in that last person, and one is ACTN2, which encodes alpha-actin 2. And they could go any further because there were no relatives to investigate. So anyway, so I looked up the alpha-actin 2 mutation, what was going on. It's a recent paper where they were using human tissue culture type things, but human cardiac myocytes up here. And you can see that they found these plaques that stained with the alpha-actin. And if so my thought is actually these could well be that. It's just a higher powers because we've got this, the set. So if we look at this diagram over here, you can see thin filament, which is actin, is here, and they're joined together at the SED band by the alpha-actinin. So it's in the right position for what I'm seeing. We've got the SED band material, it's filamentous, and I don't know about you, but to me that looks pretty, well, it fits very nicely. And we know we've got that mutation. From the skeletal muscle literature, usually they get these clumps in the cytoplasm under the sarcolemmal, but there's other differences, and they more rarely get them within the middle of the actual sarcomeric type proteins. But they have been able to, in some instances, there's various things they can do it, but they have proven that alpha-actinin 2 can be part of these clumps. So I think we have evidence that the alpha-actinin 2 mutation is certainly one of the causes. The lamin AC, which we saw in the other one, where the cardiac myocytes didn't come up staining, here are all staining. So we need to do a lot more work to see whether it should completely go away in all cases, or it's only some cases, and it varies on where the mutation is and what proteins affect, how it's affected or not. But I think, to me, this is definitely an ACTN2 cardiomyopathy with or without a lamin AC mutation. From my perspective, we have an ACM phenotype, and lots of things cause this. And so I think our role as pathologists is changing, and we now need to be working with the geneticists to work out what the cause of the cardiomyopathy is, not just say it's got a particular pattern. And this very recent paper in 2004 has come out from this European task force again, and just to cut it down, they've worked, there's a broader spectrum of structural disorders are being recognized as part of ACM. Lots of things. They've broken it down into the desmosomal genes. They broke it, the non-desmosomal genes that they're now calling genocopies. So it's a copy, it's a genetic mutation that's causing a copy of the phenotype of the original ARVC genes. They've also got the non-genetic causes, which are coming in as inflammatory, and they're now being called phenocopies because they're copying the phenotype, the pattern. So everything's copying the phenotype, and then unknown causes. And if you look at their summary and their terminology, basically they're saying all cardiomyopathies are potentially arrhythmogenic. Scarring causes arrhythmia, which I've put, we all know. And so they're talking about changing the terminology now, the disease, to scarring/arrhythmogenic cardiomyopathy, encompassing everything that has scarring that isn't ischemic. And I just put this bit in. It was interesting. So their definition of scarring. So they were differentiating this from DCM that doesn't have scarring, but I think we all know that there's scarring in DCM. So this is very much the cardiologists that are driving this and what they can see using imaging. They're starting to talk about phenocopies, and I think this is the most important thing. And they're now saying that actually we've got to accurately classify what the cause is, because the treatment and outcome may be different. So I think from a pathology perspective, I'm just going to go back. I think it's going to change what we need to do. I think we're going to have to delve deeper than just saying it's got a bit of this fibrofatty replacement. And I think it's really important that we have to separate the cardiologists and their definitions from pathologists, because the cardiologists, they see the patient, they're alive, they can't have the whole heart, which we've got. Actually they do need to keep the person alive. So they've got to come up with criteria to pick the people at risk and work out what to do. But then our job is completely different at the end. So either they've had a heart transplant, so failed management, or they've been unfortunate enough to die, and work out what's going on. So it started off as ARVC, ARVD, went around the thing. They brought in all these different variants. There's more and more mutations and elements coming up into the thing. Seems to me that they've now worked out that all of these actually are copies of that, and really ARVC should just be the original desmosomal one, except that doesn't quite, they sort of say that, but then they don't say that in the paper. And I think I've been through that, so I probably will stop there. We've got different roles, really. So open for questions.